Okay, let's unpack this. You look at, most other major developed countries, they set up national insurance systems over a century ago. Germany, for example, had compulsory sickness insurance way back in 1883. The UK gets there by 1912. But here in the US, we've been trying and, failing to do the same thing for just as long.
It's true, and that long timeline is really the story. The consistent thing is this American resistance. And what's often missed is that in Europe, the initial push wasn't just about paying doctors. Right. It was about income stabilization, protecting workers from losing their wages if they got sick. And let's be honest, it was also a way for governments to buy some political loyalty from the working class.
That context is so important. So for them, it was a broad economic and political project. But for us, it has been this 100-year war fought over ideology, interest groups, you name it. And that's our mission today, to trace this history, figure out why these efforts failed again and again, from the Progressive Era right through World War II, and how those exact same fights are still shaping the debate today around the ACO and single payer.
It's this repeating pattern. You see the same forces every time. Powerful interest groups, these deep ideological clashes, and just a political tradition in the U.S. that makes this kind of reform incredibly difficult.
So let's go back to the very beginning of that fight, the Progressive Era. The first really big national campaign kicks off in 1915, led by the American Association of Labor Legislation, or the AAL. And they drafted this model bill targeting the working class, anyone earning less than $1,200 a year.
And that AAL proposal, it shows you how ambitious they were right from the start. This wasn't some tiny little program.
Not at all.
It was comprehensive. It covered doctors, nurses, hospitals, and then it added sick pay, maternity benefits, and even a $50 death benefit for funeral costs.
$50. It sounds so small now, but that funeral benefit, that one little detail, it became a huge symbolic issue for the people fighting against it, didn't it?
It absolutely did. The idea was to split the cost three ways: the worker, the employer, and the state. But the opposition just latched onto that state involvement and the charity aspect of the death benefit.
And that's where the socialism charge really begins.
That's where it's born. It has haunted every single reform effort since.
So the debate moves into the 1920s, and you get the Committee on the Cost of Medical Care, the CCMC, formed in 1926. This one wasn't a government thing, though.
No, this was privately funded by big philanthropies. Rockefeller, Milbank. They were all getting worried about, how much care was costing and how unevenly it was distributed.
Their research was pretty clear, right? It confirmed the country needed more care and it needed to be more efficient.
Undeniable. But when the CCMC actually released its report, the committee's big recommendation was for voluntary insurance plans, not mandatory government ones.
Yeah. And even that, just the idea of voluntary groups, was treated like a declaration of war.
Precisely. The American Medical Association, specifically the editor of its journal, JAMA, just went ballistic. He called the report a radical document advocating socialized medicine. And my favorite part.
I know this one.
An incitement to revolution.
An incitement to revolution over voluntary insurance. It really shows the fear wasn't about the specific policy, was it?
No, it was about losing control, losing professional autonomy, and of course, private profits.
That fear of socialism just gets worse after World War II. It leads to the complete collapse of the next big attempt, the Wagner-Murray-Dingle bills.
Right. Wagner-Murray-Dingle, first introduced in '43. The idea was simple: compulsory national health insurance, funded with a payroll tax. It was designed to work just like Social Security.
But it ran straight into the Cold War.
Head first. This is where the red baiting becomes just unbelievable.
It wasn't just, we disagree with this policy.
Not at all. The opponents launched what was called a scathing red baiting attack. They were suggesting that key policy experts, like a guy named I.S. Falk, were secretly agents of the International Labor Organization.
Hello.
Yeah, which they painted as this, quote, awesome political machine bent on world domination. It's just, it's incredible. They reintroduced that bill for 14 straight years. It never passed.
And then President Truman steps up in 1945 with maybe the most direct push yet. His plan was really different because it was for a single, universal, comprehensive system for everyone, all classes.
Truly egalitarian. And he knew the history. He very deliberately dropped that funeral benefit that had caused so much trouble. And he kept insisting this is not socialized medicine. He was trying to sell it as economic security. But the opposition just didn't care.
They had their talking point.
They did. Senior Republican Senator Taft put it very plainly. He said, I consider it socialism. It is, to my mind, the most socialistic measure this Congress has ever had before it. He even claimed it came right out of the Soviet Constitution.
The intensity is just staggering. It
Mm.
killed the whole movement. But then something else happened that made national reform seem, well, less urgent for millions of people.
This is maybe the most important part of the whole story. The accidental creation of our employer-based system.
Right.
Private insurance just exploded after World War II, and it was cemented by the Stabilization Act of 1942.
So during the war, the government froze wages to stop inflation.
Exactly. So companies couldn't offer more money to attract workers, but they could offer better benefits, and health insurance became the big one.
A wartime measure accidentally makes healthcare a job perk.
That's it. And then, in 1954, a change to the tax code made it official. Employer-provided health insurance became tax-exempt. Suddenly, it was cheaper for a company to give you $1 of health insurance than $1 of salary.
Which created a whole new status quo. The middle class, who had been pushing for reform, were suddenly taken care of. They were cushioned. The urgency was gone for them.
It completely fractured the political coalition. You were left with the very poor and the elderly, who were still totally exposed.
And that reality is what led to the big breakthrough in 1965.
It dictated the whole strategy.
Yeah.
Johnson and the reformers, they knew a universal plan was a non-starter, so they narrowed their focus. They targeted the aged with Medicare and the poor with Medicaid.
And focusing on the elderly, that's what finally worked.
It did. Proposals like the 4M bill in '58 started to build what was called the first groundswell of grassroots support in the whole campaign. People could get behind helping their grandparents.
So the lesson from that is, in the U.S., major reform only happens if you slice up the population and, well, pay off the providers.
That's the takeaway. The final 1965 law was a political masterpiece of compromise. They had to give huge concessions to doctors guaranteeing payment for their customary, reasonable, and prevailing fees.
And the hospitals got theirs, too.
Oh, yeah. They were promised cost plus reimbursement. It basically assured the entire medical industry that they would keep control of the money, which stopped them from killing the bill.
Okay, so let's jump forward half a century, with all that history in mind, to the Affordable Care Act in 2010, the biggest change since '65.
Right. And the ACA was trying to fix the very system that had been accidentally created back in the 40s and 50s. Its goals were huge.
It expanded Medicaid to cover more of the working poor. It gave subsidies to help middle-income families buy private insurance.
And crucially, it banned denials for pre-existing conditions, got rid of lifetime caps on coverage, and let kids stay on their parents' plans until they were 26.
And you can't argue with the coverage numbers. The uninsured rate for non-elderly people dropped by more than 40%. That's about 20 million people who got coverage between 2010 and 2016.
But it immediately ran into that same historical wall of opposition. The Supreme Court, for instance, hobbled the Medicaid expansion by making it optional for states.
Which is why we still have that coverage gap in some states today.
And then Congress started to actively dismantle parts of the law.
Can you walk us through some of the things that were, intentionally set up to fail?
A perfect example is the Class Act.
Yeah.
This was supposed to be a new insurance program for long-term care, which is a huge looming cost.
Yeah.
It was in the law, but it got repealed in 2013 after opponents successfully branded it a budget gimmick.
Why gimmick?
Because the way it was designed, it would collect premiums for years before it started paying out benefits, which made the law look cheaper on paper to the CBO.
I see. And what about the co-ops? Weren't they supposed to create more competition?
Yes. The idea was to have these nonprofit, consumer-focused plans. 23 of them started up. But by 2019, only 4 were left.
What happened?
Their collapse was sped up by a hostile Congress that choked off funding for something called the Risk Corridor Program. Think of it as insurance for the insurers. It was supposed to protect these brand new co-ops if they got stuck with too many sick, expensive patients right at the beginning. When Congress starved that program, a lot of them just went bankrupt overnight.
That's a classic case of setting a policy up to fail. And then the final shot was getting rid of the individual mandate penalty.
Absolutely. In 2017, Congress zeroed out the tax penalty. The mandate was the engine of the whole thing. It forced healthy people into the market to balance out the sick people.
And when you take that away,
You get exactly what economists predicted: higher premiums and fewer people signing up because the healthy people leave.
which brings us to the biggest fight of all.
Okay.
Cost. The promise was lower premiums for the average family. If I'm a family paying thousands more now than I was then, why do I care that the rate of growth slowed down? That sounds like a talking point, not a reality.
And that's a completely fair challenge. It's the conflict between the big economic data and what's happening at your kitchen table.
Yeah.
You're right, the promise of $2,500 in savings, it failed spectacularly.
Yeah.
Average family premiums in the employer market went up by over $4,000 to more than $18,000 a year, and deductibles shot up 60%.
And critics are dead on when they say coverage does not mean care.
Yeah.
If I technically have an insurance card, but my deductible is $14,000 and my family only makes $41,000, I'm not going to the doctor.
It's the tragic flaw of high-deductible plans. But to be balanced, we have to look at the other side. The growth in national health spending did slow way down after the ACA.
Okay.
Medicare's annual growth rate, for instance, dropped to about 2%. So while costs are still incredibly high because we started from such a high place, the speed of the increase did get curbed.
So the ACA was this messy compromise built on the private market with really uneven results. Now, what are the big alternatives on the table today? It always seems to come down to single payer.
It does. And the Urban Institute has modeled a few versions. The most comprehensive one is what they call single-payer enhanced. This is the really big vision.
This is the one that covers everyone, including undocumented immigrants with huge benefits: dental, vision, long-term care.
And the key part, zero cost sharing. No copays, no deductibles.
And the cost analysis of that big plan is not what you'd expect.
It's totally counterintuitive. A more basic single-payer plan might save money by cutting administrative waste and paying doctors less. But the enhanced version, the cost of all those new benefits for everyone is so massive, it would actually increase total national health spending.
But the consensus is that if you want true universal coverage, you really only have two paths.
Right. You either have to automatically enroll every single person or you have to go to a single-payer system.
And while that debate happens, our existing system is showing major signs of stress, specifically with Medicare Advantage, or MA.
These are the private plans that manage Medicare benefits, and they are wildly popular. Over half, 54% of all Medicare beneficiaries are in an MA plan now.
And they're popular because they offer those little extras, right? Gym membership, some dental coverage, things traditional Medicare doesn't.
Exactly. And they can afford to offer them because the government actually pays MA insurers about 20% more per person than it costs to cover that same person in traditional Medicare.
But the cracks are really starting to show. We're seeing hospitals just dropping MA plans entirely. That trend has tripled in just 2 years. It's forcing thousands of seniors to scramble and find new doctors.
And the plans themselves rely on these prior authorization rules to control costs. We're seeing just horrible stories. A stroke patient waiting 6 days for their MA plan to approve rehab? Those delays are dangerous. They increase the risk of things like pneumonia or blood clots.
And then there's the famous Medigap trap.
Ah, yes.
The trap.
If a senior tries an MA plan, decides they don't like it, and wants to switch back to traditional Medicare. It's not that simple, is it?
It's not. If you're outside your initial enrollment window, private Medigap plans, the ones that cover the gaps in traditional Medicare, can deny you coverage because of pre-existing conditions.
So you can get trapped. You're trapped. The financial risk of leaving MA can be just catastrophic for a lot of older Americans.
So at the end of the day, the debate always comes back to this one philosophical friction point: compulsory taxation. The libertarian argument is pretty straightforward.
It is. Using the threat of force through taxes to take private property to pay for someone else's care.
But there's a strong counter-argument to that now. Since the law already requires hospitals to treat anyone who shows up in the emergency room, whether they can pay or not.
Right, the EMTALA law.
The people who choose not to buy insurance are already passing their costs on to everyone else who does pay. It's an externalized cost, which argues for some kind of universal buy-in.
It's a powerful point.
Looking back, our fight has been going on for over a century, and we've only had these partial victories. In Canada, for comparison, their movement started around 1916. It still took them almost 50 years to get it passed in just one province.
And that process was brutal. There were intense political fights, doctor strikes, huge rallies. It's never easy.
The lessons here are the same ones we saw in the 1920s. Our efforts get derailed by interest groups, by ideology, by this deep-seated fear of socialism, and by the fact that the private system works well enough for a lot of the middle class that they drop out of the fight for reform.
But policy has to evolve. There's a great quote from the medical historian Henry Sigerist. Someone quoted something he'd written years earlier, and he just said, 3 years is a long time. I've changed my mind since then. The debate can't be frozen.
And it has to evolve to fix the central problem of our current market, which is adverse selection. healthy people opt out, and premiums go up for the sick. The ACA's mandate was supposed to fix that, but it was repealed.
So if you want to keep the popular part guaranteeing coverage for pre-existing conditions without making insurance unaffordable for the healthy, you have to completely rethink how we do subsidies.
Right now, subsidies are all about your income. But here's a thought. What if, instead of basing subsidies just on income, we tied them to an applicant's health status?
Like the risk adjustment model they use in Medicare Advantage.
Exactly. So insurers would get paid significantly more money for enrolling sicker patients.
That's a fundamental restructuring of the entire market. You're taking the patient who is currently